Imagine you're evaluating a patient in the clinic, right? For a chin augmentation. You look really closely at their bite, and it's perfectly aligned.
Right, the teeth are completely straight.
Exactly. So you proceed with a standard surgical plan based on that observation, only to realize postoperatively that you've basically built your entire reconstruction on shifting sand.
Yeah, that's a classic mistake.
You just fell for like the most common and honestly the most heavily tested trap in lower face aesthetics. So, welcome to this revision deep dive. Our mission today is highly specific.
We are mastering genioplasty.
Right, the surgical modification of the mandibular symphysis, specifically for your board exams. We're talking high-yield facts, precise anatomical margins, and the exact clinical traps examiners love to set.
No wasted time, no fluff. This is critical information you need to actually secure points on exam day.
Exactly. But really quickly, before we make our first conceptual incision, a quick instruction for you listening. Head over to medsynclimited.com to get the FRCS Plastic Surgery Anki Deck.
It's a lifesaver.
It really is. It contains over 6,000 questions arranged by topic to help you aggressively recall the key facts we're discussing today. And it's directly based on the textbook, Keynotes in Plastic Surgery. It's an essential tool for locking in this knowledge.
Because, I mean, active recall is the gold standard for surgical board prep, right?
Right.
Which is exactly the framework we're applying to this discussion.
Right. So we're running this as a rapid-fire question and explanation session, just extracting the most testable facts. Let's jump right into the preoperative assessment and that clinical trap I mentioned earlier.
The history trap.
Yeah. Before a surgeon even thinks about the operative approach, board exams love to test the initial consultation. So when we're taking a history for genioplasty, what specific previous treatment must we actively hunt for in the patient's record? And, why is missing it such a critical error?
Well, you must specifically interrogate the patient regarding any previous orthodontic treatment. Like, if you omit that single question, you risk completely misinterpreting the underlying skeletal anatomy.
Because the orthodontics, they camouflage it, right?
Exactly. Successful orthodontics can entirely camouflage a Class II malocclusion. The orthodontist has successfully tipped and angled the teeth so that they meet perfectly in a normal bite.
Right.
But that dental correction might be masking a mandible that is structurally deficient and retruded.
So the teeth have been moved to compensate, but the basal bone of the jaw is still sitting too far back.
Right. But the skeletal deficiency is still there, hiding in plain sight behind a perfect smile.
Wow. Okay, so the superficial bite looks fine, but the foundational bone is inadequate.
Exactly. And if you miss that detail in your history taking, you're going to plan an isolated chin procedure when the patient actually requires a much more comprehensive orthognathic intervention, to correct the underlying skeletal discrepancy.
Because the chin and lower facial height always have to be evaluated in the context of the entire facial framework.
Right. You can't just look at the chin in isolation.
Which makes sense. But assessing that framework requires objective physical boundaries. We can't just eyeball a profile in the clinic or on an exam and guess how far forward to bring the bone.
No. Examiners always want to know the hard boundaries.
Right. So what is the precise objective anatomical limit for advancing the chin before the aesthetic result becomes a liability?
Well, the critical relationship for surgical decision-making in the lower face is the dynamic between the chin and the lower lip. The strict rule you need to commit to memory is this. The chin should never be advanced further than a vertical line dropped directly down from the lower lip.
Okay, so just a straight vertical plumb line, starting at the anterior projection of the lower lip and dropping straight down toward the floor.
Exactly. If you advance the mandibular symphysis beyond that vertical plumb line, you cross a major aesthetic boundary.
It starts looking weird.
Yeah, you move from structural enhancement into creating a highly artificial, unnatural appearance. I mean, the soft tissue drape simply doesn't look human when the bony support of the chin projects further out than the lip itself.
Right.
Over-advancement is considered a glaring technical error on the boards.
Got it. So assessing this area is less about looking at a single puzzle piece and more about inspecting the load-bearing walls of a house, right?
Yeah.
Like the inclination of the incisors, the depth of the labiomental fold, the overall occlusion. Those are the framing of that house.
That's a great analogy.
Yeah, and if the framing is leaning or fundamentally flawed, just adding drywall, or in our case, just advancing the chin point isn't going to fix the structural deficit.
Right, because all of those elements actively dictate the tension and depth of the labiomental folds.
Exactly.
And while you're inspecting that framing, examining the teeth for occlusion and incisor inclination, you also have to actively scan the mouth for any evidence of tooth decay.
Oh, right.
Finding dental caries changes your entire preoperative pathway.
So if we suspect tooth decay during our examination, what's the immediate, non-negotiable next step for a board candidate?
You must obtain an orthopantomogram.
An OPG.
Yeah. A clinical visual inspection is no longer sufficient at that point. You need that panoramic imaging to definitively assess the condition of the dental roots hidden within the bone.
Okay.
And here is the crucial board fact. You cannot afford to drop. Periapical pathology of the mandibular teeth is an absolute contraindication to chin surgery.
Wait, let me underline that for you listening. An absolute contraindication, not a relative risk to manage. Absolute. Wait, just stop the surgical plan.
You do not proceed with genioplasty under any circumstances if there's periapical pathology. Because, that's an active infection sitting right at the apex of the tooth root inside the mandible.
Right, and if you pat near that.
Exactly. If you perform an osteotomy or place hardware in that area, you're opening a direct superhighway for that localized root infection to seed directly into your new surgical dead space.
That's a disaster.
The risk of creating a catastrophic deep-seated bone infection is just too immense.
Okay, so before we move off the assessment phase entirely, let's look at the actual aesthetic targets. Because the surgical endpoints aren't one size fits all, right?
No, definitely not.
And the boards will test our understanding of how these modifications differ between male and female patients. So what are the specific geometric endpoints we're actually trying to achieve here?
Well, for male patients, the aesthetic ideal typically dictates creating a wide, square, prominent chin. Visually, because of that broad, flattened anterior surface, this translates to a two-point light reflex.
Okay, a two-point light reflex when surgical lighting or natural light hits the chin pad.
Right. The bone is wider and squarer, so the overlying skin catches the light on those two distinct lateral corners.
2 points of reflection. And for female patients?
Female patients tend to require a narrower, more tapered aesthetic target. So because the bone is contoured to come to a softer, more centralized apex, it presents visually as a single-point light reflex right in the midline.
Okay, so commit that geometric difference to memory. 2-point light reflex for a square male chin versus a single-point light reflex for a tapered female chin. That is vital for answering those really specific aesthetic planning questions.
Absolutely.
All right, so we've established the structural boundaries. We know to avoid the orthodontic trap. We respect the vertical plumb line of the lower lip. We mandate imaging for decay, and we've defined our light reflex targets based on gender. So we know the goal, but how we actually achieve that advancement dictates whether the patient leaves with a natural profile or, a long-term complication. Which brings us to the great divide in genioplasty, utilizing an implant versus cutting the bone.
The big debate.
Exactly. Let's tackle alloplastic augmentation implants first. When is putting a piece of foreign material over the chin the right answer? And more importantly, what can it absolutely not fix?
Well, patient selection dictates everything regarding implants. Alloplastic augmentation is best suited solely for mild or moderate chin deficiency.
That's it.
That is the ceiling of its capability. If the patient has a severe sagittal deficiency, an implant is the wrong choice. Furthermore, an implant sits purely on the surface of the bone, right? Therefore, it does not allow for any significant alteration of pre-existing facial asymmetry, nor can it correct vertical height discrepancies in the lower face.
So if a board question presents a patient with significant mandibular asymmetry or a face that needs vertical lengthening, and one of the multiple choice options is a silastic implant, we just immediately eliminate that option.
Yes, it's a distractor answer. Implants cannot lengthen a face or fix a crooked jaw.
Good to know. But for those mild to moderate deficiencies where an implant is actually appropriate, we all know the standard material lineup, right? Silastic, Medpor, Gore-Tex. But from an exam perspective, how does the material dictate our choice of surgical approach? What's the safest way to actually get that implant into the chin?
So while these materials can technically be placed through an intraoral buccal sulcus incision inside the mouth, the submental approach is heavily preferred.
Under the chin.
Yeah, an incision made under the chin. And that is the answer examiners look for regarding safety.
Why the submental approach specifically? Walk us through the mechanics of why staying outside the mouth is safer for an implant.
The submental incision minimizes three specific highly tested risks. First, It minimizes the risk of cephalid implant migration, which is the implant migrating upward toward the teeth.
Okay, how does it prevent that?
By going from underneath, you leave the superior periosteal attachments intact. That creates a natural physical barrier that keeps the implant seated low.
Oh, that makes perfect sense.
Right. Second, it drastically reduces the risk of infection because you are completely avoiding the bacterial flora of the oral cavity. You aren't dragging a porous implant through saliva.
Which is huge.
Exactly. And third, it minimizes the risk of liptosis because you do not have to cut through the mentalis muscle from the inside to access the bone.
Got it. Okay, let's talk about the physical effect of the implant itself on the soft tissue. Putting an alloplastic implant in, especially over the existing bony structure, is mechanically it's like pitching a tent and stretching the canvas tighter over a larger frame.
That's exactly what it is.
You're adding raw volume underneath the soft tissue envelope. So what does this added tension do to the labiomental fold above the chin?
Well, placing that alloplastic volume pushes the soft tissue of the chin pad outward and forward. And because the tissue is tethered, the crease above it, the labiomental fold, naturally becomes drawn in and significantly more pronounced.
So it deepens.
The implant functionally deepens the fold.
Yes. Which establishes a strict physiological rule for patient selection.
Right. Because it actively deepens the fold through that tenting mechanism. Alloplastic augmentation is completely contraindicated for patients who present with an already deep labiomental fold.
Wow, okay.
If you place an implant in that patient, you will severely exacerbate the feature. You're creating a deep, unnatural groove that just compromises the entire aesthetic harmony of the profile.
Makes sense.
And there's also a major long-term mechanical issue with implants that the boards love to test. They carry a significant risk of eroding into the underlying mandible over time.
That's just basic biomechanics at work, right? You have a tight mentalis muscle and soft tissue envelope constantly pushing backward against a rigid synthetic implant.
Exactly.
That constant pressure against the underlying cortical bone causes pressure resorption. It's like Wolff's Law acting in reverse. The bone literally just gradually melts away under the implant.
Yeah, it's a fundamental structural limitation of the alloplastic technique that candidates absolutely must recognize.
Okay, which brings us to the natural pivot in our surgical decision tree. Because alloplastic augmentation deepens the fold, it can't fix asymmetry, it can't lengthen the face, and it carries the risk of eroding bone. We have to look to the much more powerful technique.
Right, the osseous genioplasty.
The versatile workhorse. So how does actually cutting and moving the bone, a sliding advancement genioplasty, overcome those severe limitations of implants?
Well, it overcomes them through absolute multiplanar versatility. With an osseous genioplasty, you're mobilizing the foundational bone itself.
Yeah.
That segment of the chin can be moved in literally any direction.
Any direction.
Right. This allows the surgeon to perform simultaneous correction of multiple complex issues in a single operation. You can advance for deficiency. You can shift it laterally to perfectly correct asymmetry. You can impact it or graft it to alter vertical height. And you have precise, independent control over the tension and depth of the labiomental fold.
So you aren't just stuffing a piece of silicone under the carpet, you're re-engineering the actual floorboards.
Exactly.
Walk us through the surgical approach for this osteotomy. What is the critical safety margin we need to quote for the exams when we're, applying the saw blade to the mandible?
Okay, for an osseous genioplasty, you typically utilize an intraoral buccal sulcus approach. You make your incision inside the lower lip, which requires you to dissect directly through the mentalis muscle to expose the symphysis.
Okay.
Once the bone is exposed, you use a reciprocating saw to make a horizontal osteotomy across the chin. And the critical safety margin, the specific number that shows up repeatedly on multiple choice exams, is approximately 4 millimeters inferior to the mental foramina.
Okay, 4 millimeters below the mental foramina. What's the underlying anatomical mechanism for that specific number? Like, what structure are we giving that 4 millimeter buffer zone to?
That margin is non-negotiable because it provides the necessary physical clearance to protect the inferior alveolar nerves as they exit the mental foramina to become the mental nerves.
Right, the nerve needs space.
The nerve requires space, and the saw blade has a certain thickness known as the kerf. If you make your horizontal osteotomy any higher than 4 millimeters below those foramina, you obliterate that safety buffer and risk catastrophic, permanent transection of the nerve.
All right, so we've respected our 4 millimeter margin, made our safe horizontal cut, and we've slid the bony segment into the new desired position, let's say, to fix the patient's asymmetry. How do we secure that floating piece of bone? And how do we handle a patient who specifically needs vertical elongation? The exact issue we noted an implant could never fix.
Once the bone is maneuvered into the perfect position, it must be fixed rigidly to ensure proper healing. This is accomplished using either intraosseous wires or, more commonly now, a titanium plate and screws.
Okay.
Now, if the preoperative plan demands vertical elongation, meaning you need to drop the chin segment inferiorly to lengthen a short face, you create a physical gap in the bone.
Right, you pull it down.
Yeah, so you must interpose a bone graft substitute into that osteotomy gap to hold the chin down. And the specific material heavily cited in board literature for this purpose is hydroxyapatite blocks.
Hydroxyapatite blocks.
Right. You wedge those blocks into the gap to maintain the vertical drop and then apply your rigid fixation directly over the construct.
Okay, that dictates the bony reconstruction perfectly. But let's look at getting out of the surgical site. We mentioned earlier that the intraoral approach requires dissecting straight through the mentalis muscle.
Yes.
What's the mechanical consequence if, say, a resident is rushing their closure at the end of a long case and fails to meticulously repair that muscle?
Well, this highlights an incredibly important post-operative deformity. The mentalis muscle is not just superficial tissue. It acts as the primary elevator of the lower lip and the suspensory hammock that holds the soft tissue chin pad in place.
Okay.
Failure to structurally repair the mentalis muscle leads directly to the witch's chin deformity.
The witch's chin. Break down the actual presentation of that deformity. Like, what happens when that suspensory hammock is left compromised?
Because the muscle has retracted and is no longer providing upward tension, two distinct clinical features emerge. First, lower lip incompetence.
Meaning they can't close their mouth.
Right. The patient physically struggles or is completely unable to fully close their lower lip against the upper lip because the elevator mechanism is broken.
Wow.
And second, chintosis. Without that muscular suspension, gravity and scar contracture pull a heavy soft tissue of the chin pad downwards, causing it to literally droop off the bone.
That sounds awful.
It is. Reapproximating the mentalis is absolutely paramount to preventing the witch's chin deformity.
Lower lip incompetence and a drooping chin pad. I mean, that is a devastating functional and aesthetic failure to see at the follow-up clinic.
Completely.
All right, so we've covered the structural assessment, the strict boundaries for advancement, the indications for implants, the 4mm safety margin for the osteotomy, and the critical importance of muscular repair.
We've covered a lot.
We really have. Now we need to lock down the final high-yield topic for the FRCS exams, the overall surgical complications of genioplasty. While complications are, relatively rare in experienced hands, the board exams demand we know the hard statistical numbers.
They absolutely do.
So what are the specific percentages and named risks we need to memorize?
The examiners will definitively test your knowledge of these specific risks and their associated occurrence rates. The most common specific sensory complication following genioplasty is lower lip paresthesia, and that occurs at a documented rate of 5%.
Okay, a 5% rate for lower lip paresthesia. That ties directly back to those inferior alveolar nerves and the mental foramina we protected with our 4mm margin rim.
Exactly.
But even if the surgeon follows the rules perfectly and doesn't actually cut the nerve, that risk remains.
It does. The mechanism there is indirect trauma. Even with a perfect osteotomy that respects the 4mm margin, the necessary surgical traction from or even just standard post-operative tissue swelling can compress or stretch the nerve.
Oh, sure.
And that results in that 5% rate of transient or sometimes permanent paresthesia.
Okay, 5%.
Moving down the list, you must know the specific rate for soft tissue infection. That stands at 3%.
5% for sensory paresthesia, 3% for soft tissue infection. Which makes sense given the placement of permanent hardware or implants. What are the other named complications on the board's checklist?
The other key complications include dental root injury, which just reiterates why the precise horizontal osteotomy placement and the preoperative OPG are so fiercely critical.
Right.
Then there's hematoma formation within the surgical dead space. And finally, malposition causing an undesirable cosmetic result.
Malposition, meaning the surgeon pushed the chin segment completely past that vertical plumb line from the lower lip, or they just failed to adequately calculate and correct a pre-existing asymmetry.
Exactly. Technical errors translating directly into aesthetic failure.
Right.
But for the rapid-fire multiple-choice questions, you must drill those specific numbers. A 5% rate for lower lip paresthesia and a 3% rate for soft tissue infection.
Got it. Let's bring this all together for you listening and preparing for your exams. Mastering the distinct physiological differences and indications between alloplastic augmentation, which, remember, is reserved for mild to moderate deficiency only, and deepens the labiomental fold and osseous genioplasty, which is your versatile, multiplanar workhorse for fixing asymmetry and vertical height, is crucial.
Absolutely crucial.
Combine that conceptual understanding with those hard numbers. The 4 mm safety margin inferior to the mental foramina, the 5% risk of lower lip paresthesia, and the 3% risk of infection. Knowing not just the facts, but the structural mechanisms behind them is exactly what will secure your points on exam day.
Because understanding the physical why, like how a submental approach leaves the superior periosteum intact to prevent cephalid migration, or how the mentalis muscle acts as a suspensory hammock to prevent the witch's chin, that's what allows a candidate to really reason their way through the most complex, convoluted clinical scenarios the examiners will throw at them.
Exactly. If you found this rapid-fire, high-yield review helpful for your FRCS prep, press follow on the show right now so you don't miss our upcoming revision deep dives. And please leave us a rating if you learned something valuable today. It really helps us keep bringing you this targeted content.
And utilize the tools available to you to turn this audio review into permanent knowledge.
Yes, head over to medsynclimited.com right now and grab the FRCS Plastic Surgery Anki Deck. With over 6,000 questions arranged by topic based on the textbook Keynotes in Plastic Surgery, it is the fastest, most aggressive way to implement active recall.
Highly recommend it.
Now, we're going to leave you with a final, totally different thought to mull over before your next long clinic shift. As you study these osteotomies and the dense cortical bone of the symphysis, consider this: humans are the only hominids on Earth with a true projecting chin.
It's pretty fascinating.
It is. Neanderthals didn't have them. Great apes do not have them. Next time you look at a lateral cephalogram, ask yourself, what evolutionary biomechanical purpose does this thick projecting bone actually serve for human speech and managing chewing stress?
It fundamentally changes the way you view the architecture of the lower face.
It really does. And we want to hear from you on this. Drop a comment or a question below about your own strategies for assessing subtle Class 2 malocclusions when the orthodontics are actively trying to fool you. Until next time, keep reviewing, keep pushing, and we will see you on the next deep dive.